as they join. Just going to get organized here. Okay, so welcome to a Connected Care webinar. Maybe thumbs up if everyone can hear me. Is everything okay for you on your end?
Oh, good here.
Thank you. Great. Okay, so welcome to a Connected Care webinar where the focus today will be on the ResMed Astral ventilator, which is the ventilator to replace the Trilogy previously distributed to patients requiring invasive home ventilation. My name is Faiza Syed. I'm a respiratory therapist and clinical educator with the Connected Care program at SickKids. You may be joining us today after having experience with the Trilogy or having taken the Connected Care invasive ventilation workshop or just-in-time training. This will help you in preparation to take care of a client on the new Astral ventilator. I will be reviewing some ventilation basics, but it is recommended that you attend the invasive ventilation workshop or just-in-time training session to learn more on this topic if you do require a ventilation refresher. We are recording today's session, and this will be available on our website shortly. Our primary focus will be this PowerPoint presentation, so you can keep your screen enlarged on this. Here are some webinar guidelines for you to review. Also, please take a few moments now to review the disclaimer. Okay, over the next 90 minutes, I hope to cover the following objectives. To explain the safe and effective setup of the invasive ventilation setup of invasive ventilation via the Astral ventilator, outline the differences between the Trilogy ventilator and the new Astral ventilator, and review alarm management. Currently, the main ventilator used for pediatric invasive home ventilation in Ontario is the Philips Respironics Trilogy 200 ventilator. The Trilogy 200 is being phased out and will be replaced by the ResMed Astral 150 model. New patients needing invasive home ventilation will now receive the Astral 150. Existing patients using the Trilogy 200 will gradually transition to the Astral 150 with support from clinical teams and the Ontario Ventilator Equipment Pool program over the next 6 to 8 months. Also make note of the Ventilator Equipment Pool website for additional resources, because I will be referring to them as we go along. So it's ontvep.ca. This is a quick review on what mechanical ventilation is. It is assisted ventilation delivering flow and pressure to the airway to affect the lung volume. A mechanical ventilator is a machine that generates controlled gas flow into the patient's airway, and ventilation can be achieved through invasive or non-invasive methods, non-invasive being mask ventilation. The ideal breath on ventilatory support should synchronize with the child's spontaneous breathing efforts. It should maintain an adequate volume of air or oxygen in the lungs, and this is known as tidal volume. And on many home ventilators, the exhaled tidal volume is measured and displayed on the ventilator as VTE. And then we also want to provide ventilation at the lowest airway pressure possible, just so that we don't overpressurize these fragile pediatric lungs. Here are some reasons why children may require help with their breathing. So, for example, conditions that affect respiratory muscle performance. Examples of such conditions include spinal muscular atrophy, SMA, or Duchenne muscular dystrophy, DMD, or other types of dystrophies or myopathies, or even muscle deconditioning after a lengthy illness or injury. Children with central issues, so one example is congenital central hypoventilation syndrome, or otherwise known as CCHS. In this rare condition, patients hypoventilate when asleep, and they require mandatory ventilation support. Pulmonary disease, such as chronic lung disease, so CLPD, CLDP, or BPD, bronchopulmonary dysplasia. This is characterized by swelling and irritation and scarring of the lungs. And then another indication is chest wall deformity conditions that alter the structure of the chest wall and affect the functioning of the pump, and then may result in respiratory compromise, thus, the child requiring support. It's good practice to have some understanding of changes in the child's measured parameters. So exhale tidal volume, which is the amount of air or oxygen the child has exhaled, total respiratory rate, and leak are all displayed on the device's monitoring page when the child is ventilated. These are some of the key parameters to be aware of. And here you'll see these measured parameters are displayed on how they're displayed on the Astral compared to what you're used to seeing on the Trilogy ventilator. So why are these important to know? So for example, if the tidal volume exhaled is low, you may notice an elevated leak value. And in this scenario, you will have to check for leaks. So for example, you would check for any leaks around the trach that's directing air to the upper airway instead of back into the ventilator circuit. Inadequate cuff volume, if the child has a cuff tube causing leaking around the cuff or leaking elsewhere in the circuit, such as in, the connections, or even if the child's position is off, and their head position is allowing for additional leaking, you may also need to suction the patient. So lots of different reasons. Here's a review on intentional versus unintentional leaking. So intentional leaking is the leaking out a leak valve, or also known as the exhalation device or exhalation port. This is the circuit. It is definitely circuit dependent, but we expect that most children will have this circuit type. The leak valve is where the child breathes out. Unintentional leaking is what is the leaking that we do not want. So we would want to minimize such leaking, as explained in the previous slide. And it's important to note that leak is displayed differently on the Astral compared to the Trilogy. So on the Trilogy, it displays intentional plus unintentional leaking. So the leaking that comes from the leak valve. On the Astral, only the unintentional leaking is displayed. So you'll see smaller numbers than what you're used to seeing on the Trilogy ventilator. It's important to know that each child will have their own range of leaking, and what you need to be aware of if the leak is abnormally high for the patient, and the actions to take to minimize that leaking. And we often don't see zero leaking, especially with so we often do we see leaking, so we don't see zero leaking with a lot of our primarily uncuffed tubes. And so there's always a little bit that the ventilator does have to compensate for, and it'll do that automatically. So you will see some sort of a small number usually. If the leak is too high and the ventilator can't compensate or control the leak, then a high leak alarm will sound. Here is a review on what the settings mean. So the settings are discussed in our introductory invasive ventilation sessions. Feel free to take a screenshot of this for future reference, but it's also available in the pre-readings and in the Astral manual that's available on the ventilator equipment pool website. There could be slight differences in which settings are offered in which mode or circuit type, but overall these core settings are similar on the Astral as they are on the Trilogy. Okay, here are some new settings on the Astral that are not offered on the Trilogy, and you may see these depending on the circuit type or mode chosen. So our clinical staff is also just getting used to these new settings, but essentially we have safety tidal volume, which sets the minimum tidal volume for each delivered breath. And this way we can guarantee that the child receives at least a certain amount of volume in the face of leaking or a changing patient condition. So when the safety tidal volume is set, then a maximum pressure is also set to ensure that the extra volume is not overpressurizing the lungs. Now, let's get into the specifics of the ventilator. So here you'll see a bedside Astral setup with the heated humidifier inline, and we'll go through each component. So on the front of the Astral, you'll see a circuit adapter, which is also known as an expiratory port. There are three different types for each circuit type offered by this ventilator. They're already set in place by the clinical team, so you shouldn't have to put it in or replace it. Families are shown how to do this for cleaning purposes. And there are resources available again on the ventilator equipment pool website if you need to look into this. Number two is a carry handle, and number three is the inspiratory port where the air exits the ventilator. So the breathing circuit will get attached here, and this is the air that goes to the patient. The back of the device, so there are some important parts listed here that you will need to know about. Number four is the power inlet. The AC power cord gets connected here. Number five is the on and off power button to the device. It may take about a second or two for the device to respond, so just be patient when you press this. Number six is the air inlet filter. This is where the air enters the machine. There is a filter inside that needs to be replaced every 6 months and inspected monthly for dust or dirt buildup. So family caregivers are taught this as well. And if you'd like to learn to assist this or assist family with this, then there is a video on the ventilator equipment pool website to look at. Number seven is the oxygen inlet connection, and I'll show you more on this in the upcoming slides. And then number eight is where a provided USB stick will be used to upload the data for the clinical teams to look at. This is the front panel when you're facing the screen. So number one is the touchscreen interface. Number two is the power source indicator. So this will let you know if the unit is running off AC, DC, or internal battery power. Number three is important. This is the therapy on-off indicator. If the light is constant green here, the device is on, but it's not ventilating. If it's flashing blue, then the device is ventilating. Number five is the alarm bar, and this will indicate the priority of the alarm in the alarm display. Alarms are classified into high, medium, and low priority according to the severity and urgency of the alarm condition. So for example, a high priority alarm will respond red. So for example, these would be alarms like low minute ventilation, a circuit disconnection, a high pressure alarm. You can find a complete list in the user manual as well. The recommendation, of course, is to respond to all alarms in the same manner to ensure the safety of the child. Okay, so while the therapy is on, you will see a pressure bar on the left-hand side of the screen. It'll be active. So number one is the measured peak inspiratory pressure displayed per breath. So it'll, the numbers will be sort of moving up and down all the time, and it will show you the sort of that max pressure. Number two is the indicator to show that the patient is triggering exhalation, so when they're actively breathing out. Number three is the marker to show the maximum set pressure. Number four is where the current pressure is at, so that's the green bar there. Number five is the PEEP or EPAP, so the lower pressure value. You see it as a faint yellow line there. And then number six is the indicator to show when the patient is triggering a breath. So when they're triggering to inhalation. wanting to take a breath in. Okay, now let's take a look at the main screen while the therapy is in the standby mode. And this is what you will see before you start the patient or client on the therapy. So number 14 is the clinical mode access button, and you'll see this icon locked, and you're kindly asked not to adjust this. Number 15, programs are set for each patient. The active program is the one that's highlighted in orange. These programs can be custom labeled, and hopefully when you get your orders, the labels will match your orders. So here, for example, program one, or for example, like program one can be set to like a day prescription, and program two can be set to a night prescription. The clinical teams may set, for example, additional ones for, let's say when the child is sick. So they might have like sick settings. And on your care plan, you'll have guidance on when to switch to this, and you'll partner with the family to do that. And the clinical teams may set up to a maximum of 4 programs that are allowable on this ventilator. And just always make sure that you clearly see, you clearly know which programs are available, and that you have orders, or in the care plan, it's clearly outlined all the parameters for each of the orders. Number 16 is the information bar, and I have more coming up on this in the next few slides. Number 17 is the internal battery indicator. So when the ventilator is in standby, you'll see the percentage of battery charge level that's displayed here. However, when the battery is being used, so off AC power, you're out and about, or power's out and you have to use the internal battery, it shows the remaining usage in the number of hours. Number 18 is the touchscreen lock button. So when the screen is locked, the button will be highlighted orange. To unlock, you just touch anywhere on the screen and then follow the prompts. And then to lock, you just press this icon again. Number 19 is the menu bar. We'll review this also in the upcoming slides. And then number 20 is the start and stop ventilation button. And here, to press and hold so when you're stopping ventilation, you want to press and hold until you and then release the button until the prompts on the screen indicate for you to do so. There will be a confirmation message to say, to confirm whether you would like to, in fact, stop ventilation, and you would press that, and the machine will stop the ventilation. The power to the device is still turned on at the back of the device when you initially did that, but the ventilation part of it, so the flow of air, will be stopped. Okay. To toggle between the programs, on the main screen in orange, you will see the program that is currently set. So number 2, you want to select the desired program, and then number 3, the settings and alarms of the program will then appear, and you want to just verify that these settings and alarms are accurate as per the orders you have. And then number 4, you want to press confirm to change to the new program. The information bar is displayed at the top of the touchscreen, and that displays the patient type. So here, for example, the adult mode is shown. It'll show you the circuit type. So here, for example, the double limb circuit is shown, and we'll review more on what a double limb circuit is, because I expect that it'll be new for most of you. You'll also see the type of program that's being used here. So in this example, you see P1, so program 1. The mode of ventilation, so you'll see here it's shown the ACV mode is used here. In pediatrics, we use a lot of like PC or PC SIMV modes. You'll see that displayed at the top. And then you'll also see any informational messages. So here, for example, is telling you that it's on standby mode. You might also see the type of alarm that's occurring, and of course the power status as well. Okay, and then on the right-hand side of the screen, you'll see 4 menus. So number 1, the lungs icon represents the monitoring menu. Number 2, the button with the check marks represents the setup menu. Number 3, the alarm bell icon represents the alarm settings, and then the I is the information summary, and I'll go through each of these now. So the first button on the right-hand side is the monitoring button, and you'll see then 3 sub-menus that pop up on the left-hand side. So waveforms, monitoring, and trends. So while the device is connected to the ventilator and receiving therapy, you can view live detailed ventilation information through the monitoring submenu. Previously, I showed this same some of the information or parameters. It was like a little bar at the bottom of the screen. You can leave it on that main screen and not really go into this if you don't want to, but here it just shows it to you in a larger format, and it has some additional numbers as well. Um, and again, most prefer to leave it on on that, just the bar at the bottom, just because so that there's not a lot of toggling back and forth. But once again, you can look at relevant parameters such as the pressures, the tidal volume, respiratory rate, and leaking. Okay, next is the setting menu on the right, and you'll have 4 sub-menus that open up on the left. The one that will be of relevance to you in home practice is the settings sub-menu. When you select the settings sub-menu button, um, the uh, the clinical parameters are displayed. So this is where you're going to check all your settings against your orders that you have on hand. Okay, so the main settings for the patient. And then the alarm checks are on the next page. So here is the alarm menu. So when you select the alarms button on the right-hand side, there are 5 tabs. So there's no, so it's not like the sub-menus appearing on the left-hand side, but you'll see tabs going across the top. And then you can check each tab to verify the alarms that are set, and then against the orders that you have on hand. And then the last button on the right-hand side is the information button. So when you click this, there are 3 sub-menus that open on the left called Events, Device, and Battery. Under Events, you can see which alarms have changed or have been previously activated and reset. And you can also see again what settings and alarms have been adjusted, if any. You will now do, so I'll now go through some of the power options available on the Astral ventilator. It is recommended that you keep the ventilator plugged into AC power at all times. This will keep the internal battery charged. And this is on the invasive ventilation safety checklist from Connected Care. So have a look at that as well. Families will also get an external battery funded just like they did for the Trilogy ventilator, with an adapter that gets connected to the back of the ventilator also. And families may have purchased an additional car charger adapter, but that's up to them. So the power cord is equipped with a push-pull locking connector. So to connect to the power cord, you simply push it in. To remove it, however, you have to grasp the outer housing, so the round part there, pull that back, and then with your other hand, pull back the power cord. So what you never want to do is twist the power cord from the outer housing, or just force the power cord out, because it can break the collar very easily. Okay, so the ventilator has an 8-hour internal battery. When the ventilator is connected to AC power, the internal battery will charge up. When the AC battery is disconnected, the ventilator will automatically switch to using the internal battery. And of course, assuming that the external battery is not connected, because if the external battery is connected, it will prefer using that battery. There is no interruption to ventilation when this happens again. The ventilator will notify you of this change by sounding an alarm and a message on the screen that will show you the current internal battery life amount. There will be slight variations in the battery life depending on the individual child's ventilator parameters, their respiratory pattern, whether they're using the ventilator on a cold wintry day, and whatever sort of external pull the battery might have on the ventilator. So always check the internal battery indicator carefully, and be mindful of that when you're using it on battery. And then just at the beginning of the shift, always make sure that the unit is plugged into AC power. So like I said, the external battery is available for the Astral. It may look like this. The one you had for the Trilogy was a lot larger. So the external battery will provide power up to 8 hours. And again, it also depends on the child's parameters and the conditions of the ventilator, and the life of the battery itself. Um, you know, Families will get one battery, but if they choose to purchase a second one, batteries can be connected in tandem on this ventilator. You'll see the green charging lights on the battery or on the charger itself, on the front. And there is a external battery guide on the ventilator equipment pool website that shows you in a bit more detail about the charging. Car chargers. So when using a car charger adapter, if the family has purchased one, just be mindful to start the car before connecting the adapter. And if for any reason the power source drops, the ventilator will then automatically switch to internal power. Okay, here is the cleaning and maintenance chart available also from the Ventilator Equipment Pool website, and families are provided this when they are trained. Some differences from the trilogy that you might see. So number one, the ResMed leak valve. So as mentioned, you might see this type of leak valve, or those that you're familiar with seeing on the Trilogy. And I do have another slide coming up on this. For this one in particular, the ResMed leak valve, it is recommended to wash daily with soap and water, rinse well, and then air dry. And it needs to be replaced at weekly. Unlike the other ones that are called DEP valves or whisper swivel valves, those ones are washed weekly and replaced annually or when they get broken. So just be mindful. If you have this particular kind, the ResMed leak valve, that it's washed and replaced more frequently. Okay, we'll now move on to Astral circuit setups. And to remind ourselves what a circuit is, so the air and oxygen travels from the ventilator to the patient through tubing, or what is known as the circuit. So a circuit includes the tubing, the wires, and any patient connector, and it can be small or larger diameter, and this will be determined by the clinical teams based on the child's age and size. And there are different circuit configurations. So one is called a single limb with leak. This is otherwise known as a passive circuit, and this is what you're used to seeing on the Trilogy with most of our patients. And I'll go through each of these circuit types. The new one is called dual limb, and there will be patients on the dual limb, likely some of the younger patients, and I'll be going through that as well. For the leak one, we will also have children. There are some children that are on non-invasive ventilation with a mask, and they will be on the single limb with leak or passive circuit as well. And we'll go through each of these. And you'll see the type of circuit on the child's care plan. So just keep an eye out for that and make sure that is in fact the one that's set. First, let's go through types of circuits. So circuits can be heated or non-heated. Non-heated tubing is typically reusable and is washed weekly. It's used with the transport ventilator with an inline HME or heat and moisture exchanger for humidity. And we call this a dry circuit because there's no active high heated humidity going through it, which would potentially cause a lot of condensation. So that's with the bedside circuits. The bedside circuits are known as heated circuits. They are disposed of weekly, including the canister. The gray wires are wiped down, and the auto feed water bag is reused for 2 months and washed weekly. The heated tube can come with an auto chamber that is auto fed by the water bag, or with a reusable water chamber, which is just a little bit bigger. And if there is a reusable water chamber that does not get disposed of weekly, we wash that and use it as long as it's in good condition. So the current Trilogy bedside looks like this on the left, and the Astral vents may be on a stand, similar stand, but we are also offering families a tabletop stand. So it's a little table that secures the ventilator on one side and the heated humidifier right beside it. And we'll leave this decision up to families. The circuit adapters, so there are 3 different types which the clinical teams will um, set as appropriate for the patient. So number 1 is the type that you'll see for the single limb with leak, like the passive circuits. Number 2 is the one you'll see with the dual limb. We don't expect to see single limb with an active exhalation valve. There are a few patients with that, but the first 2 we'll be seeing predominantly. Okay, so the Astral setup looks like this, the bedside setup. So the Astral is a lightweight ventilator. It's about 7 pounds compared to the Trilogy, which is about 11 pounds, and it's a little more boxier. With the Trilogy, you actually have to, get up and look down on the screen to see all the parameters and activity on the front screen. With the Trilogy, you could just, stay seated and you'd be able to see it right in front of you. Number 2, so this is a trach adapter, but if the patient is non-invasively ventilated, you'll see a mask in place of the trach adapter. Number 3 is the actual tubing. So it's here we've shown a disposable heated circuit setup, and this is what you'll see for most patients at the bedside. Number 4 is the exhalation port, or the leak valve, and this is for the leak circuits, or this particular circuit setup, which is the passive circuit. Number 5 is the heated humidifier, which is the Fisher and Paykel heated humidifier that you've seen with the Trilogy as well, and this will stay the same. And then you'll see gray wires that are the communication wires for the humidifier. And then number 6 is the filter. So this filter cleans the air coming in through the ventilator device, going to the patient, and prevents any splashes of water going back into the ventilator. Hopefully it won't go back in. Okay, here's the water bag and autofill chamber setup. So the water bag should be disinfected weekly using, we teach families to use chlorine-based sterilization tablets that are suitable for drinking and, cleaning baby bottles, etc. And we disinfect them in cold water to prevent the bag from any damage, and then replace the bag after every 60 days or earlier if it becomes discolored. So the tubing, the disposable tubing and bag, they are provided by the ventilator equipment pool for families. Okay, so let's get into the different circuit types. So here we have the single limb with leak, or the passive circuit. So in this circuit, we must have a leak like we did for the Trilogy ventilator. And so what you see here is at the outlet of the device where the air comes out, you see the antibacterial filter. You'll see a small tubing directing the air to pick up the humidified air from the heated humidifier. That warm, moist, humidified air then exits the humidifier, goes into a long tubing, and that long tubing continues directed into the trach adapter, into the child's trach and into their lungs. When the child exhales out, it goes back into the ventilator circuit and then exhales out, or leaks out of the leak valve. So this is where the child is actually breathing out from. And Again, this is called a wet circuit because you have that, heated humidification and condensation buildup. So the dry circuit for this, for the single limb with leak, is this is for traveling. And so what you have here is you would plus or minus a filter on the exhale, sorry, where the air comes out of the ventilator. You would have long tubing going, directing the air directly to the patient. When the patient breathes out, their exhaled air and moisture and warmth of the air gets trapped in the HME filter, and then it continues, and the child then breathes out of the leak valve. So we always want to make sure that leak valve is not covered. And so the one shown here is the ResMed leak valve, the one at the top here. But the other four are ones that we've been using previously on the Trilogy, and we will continue to use those as well. Okay, this is a circuit type that is likely new to many of you who have only previously worked with the Trilogy. So it's used, so we have dual limb circuits used with ICU ventilators all the time, but with home ventilators, especially in Ontario, it's new. And the reason we use it in peds sometimes is because this circuit type or configuration is a bit more sensitive to younger patients and their ability to trigger the device. So dual limb means that the air coming from the ventilator on inhalation um, is then, so it goes to the patient. So in the same way, it's directed to the humidifier, comes out, long tubing goes into the patient. So air is directed into the patient's lungs on inhalation, patient breathes out. And instead of having that leak valve, that the air is actually directed all the way back into the ventilator. There is an outlet at the bottom of the ventilator where the air actually comes out, but it's directed all the way back into the ventilator. So it's called a closed circuit. So there's no leaking. Again, it's used for younger children typically to make triggering a little more sensitive for the babies. And you might see a smaller size tubing with this, like a smaller diameter tubing with this as well. Okay, here is the a double limb circuit in a travel setup. So you will see the air exiting the ventilator, coming into the breathing circuit, passing the HME filter, going into the patient's lungs, and then when the patient exhales out, that moisture, air, and heat will be trapped in the HME filter, but the air will then continue back into the ventilator for measurement, keeping it a closed system. And there's an obviously there's an exhalation sort of device at the bottom where the air is exhaled out. Okay, this is the third type of circuit configuration. It's called a single limb with active expiratory valve. So here what we have is a valve that is closed on inspiration, and then it'll automatically open up on expiration. And so it keeps it a closed circuit, no leaking when the air is directed into the patient. But when the patient breathes out, through the use of the two smaller clear lines, it will open and close what we call a balloon valve, or some people call it a mushroom valve. And then so when the child is breathing out, it will open up, allowing air to come out, the exhaled air to come out from underneath here. And you will feel the air coming out. So again, we want to make sure that we're not blocking this, but this is another type of circuit configuration that you may see. And then here is the setup, single and double limb for a child on non-invasive ventilation. So you may have patients with a mask versus a trach, especially younger children or that who are not able to meet the weight requirements for the regular BiPAP or CPAP units. So what you have here again is the filter tubing that's directly to the humidifier. The air then exits the humidifier and then goes directly into the mask. So some key points here is that the masks, so you'll notice that we don't have an extra in this picture we do, but in this one we don't. We don't have an extra leak valve here. So most masks in home use are built with exhalation holes. So you always want to make sure that the child has exhalation holes in their mask. You're feeling that intentional leak coming out of the mask. If they do not, this could be a type of mask that they had in the hospital, because in the hospital, we may use one that does not have leaks built into it, and thus we have to put in a leak valve, right? So that when the patient breathes out, they have somewhere to breathe out from. So just always make sure you locate the exhalation holes and feel the air coming out of those. If you see that the child has a mask that does not have exhalation holes, you want to make sure they have a leak valve. Okay. Okay, so adding oxygen to the ventilator, this is done in the same way as you were doing with the Trilogy. So a typical prescription will be in a liter per minute flow rate. So an example would be add up to 3 liters per minute of oxygen into the ventilator to maintain saturations greater than 92%. So the inhaled oxygen concentration itself will vary depending on the mode of ventilation, the settings used, the patient's breathing pattern, and the leak rate. So for home vents, we won't know how much percentage of oxygen the patient is getting. So we have an oximeter probe connected to the patient. We'll see what the resulting oxygen saturation is when we're adding a liter per minute flow to the child's ventilator. Okay. Just keep in mind the connector is pushed in, and then the oxygen tubing is connected to that. So on the Astral, again, it's just pushed in. And if you want to take it out, there's a little silver push button. And on the Astral, you just push it up underneath and it'll pop out. But the tubing goes directly onto this, and then it'll be connected to a concentrator or large tank in the home. And then keep in mind that the oxygen should be turned off when the ventilator is not in use. And this is the only place where oxygen should be attached or going into the ventilator. There should be no other connector, for example, in line with the circuit, shouldn't be used there, because that can affect the triggering and the child's ability to trigger a breath. Okay, the heated humidifier that you're already working with on the Trilogy will remain the same. So as a refresher, press and hold the power button to turn on. You can warm the humidifier up 30 minutes, up to 30 minutes before using it. It should be, or placing the child on the ventilator. And then it should be placed in invasive mode for trach patients, non-invasive for mask ventilation. To toggle the invasive mode, simply press and hold the button beside it, and it'll toggle between the two modes of ventilation. The silence button, when pressed, will remain silent for 2 minutes. The alarm indicators will be indicated by an orange or even uh, an orange light or some sort of a colored light on the area of concern. So example, if the water runs out, it'll be displayed on the water canister on that picture. And if the temperature goes high, for example, it'll be displayed on the lungs, on the patient lungs icon. And then always make sure that the gray wires are secured and connected properly. And this is a part of the circuit and humidifier checks at the beginning of shift. So in a typical setup, there are 5 connections. So you have 2 on the side of the humidifier, so a yellow wire and a blue wire, and then 2 at the top of the humidifier canister that go in to the side of the large tubing. 1 at the side and 1 at the back of the large tubing connector. And then the last one is the one that's the temperature probe that's connected closest to the patient. So it's shown a little more here. So there's the 2 at the top of the humidifier canister, 2 at the side. Sorry, this is off, misaligned, but this is the patient connector, so it gets connected to closest to the patient. And on a dual limb circuit, you will have a 6th one, and that will be at the back where the tubing goes, the air is directed back into the ventilator. Okay. Okay, so turning the power on and off to the device. So to power the machine on or off, press the green button at the back of the device. But the ventilator can only be powered off once the ventilator has been stopped from the main screen. So remember, press and hold the stop button until the instructions on the screen tell you to confirm whether you want to turn the vent on or off, like the flow to the ventilator. Um, so starting ventilation, so the first thing you want to do again is plug the power cord into AC power, um, or the battery if you're using if you're on the go and you're using the DC battery. So press that, wait a few seconds for the ventilator to respond. Number two, you want to ensure that the circuit is clean, everything is set up appropriately, all the wires are connected properly. You want to make sure the humidifier is plugged in and turned on. There's water in the canister. And then number three, you want to check that the prescribed settings are set appropriately, as well as the alarms. And you want to do that against the orders that you have. And then you want to make sure the child is ready, make sure the oximeter is connected to the patient, and then you want to connect the trach tube, the adapter, sorry, to the patient. And then you want to press the start ventilation button, and you want to check the flow through the exhalation port. So you're assessing the patient, you're watching for the chest rise, you're watching for patient's comfort, and then you'll see that the bar on the left becomes activated. So you'll see that green bar going up and down to show you how the patient is breathing in and out. And then the last thing is if you have oxygen prescribed, you want to connect the oxygen tubing, if it's not already connected, to your oxygen source, and then you want to set it to the liter per minute flow. Okay, so alarms can, of course, alert you to a problem with the child. So ensure that you familiarize yourself with the set alarms for your patient, which should be on your care plan. And on this slide, we'll review the what is associated with an alarm. So number one is the alarm display. So this displays the highest priority, so the active alarm or the last active alarm. If if it hasn't been reset, and you could just reset an alarm. So if an alarm is not active anymore, you could just press the alarm mute button to reset it. Number two is the active alarm screen. So this will display all the active alarms. Number three is the information menu, and this shows a history of the alarms. So in case you're ever talking to a clinician or somebody in connected care, and you're sort of going through the history saying this alarm keeps going off and it's gone off this many times and I'm trying to figure this out, so good to know where that information lies. Number four is the alarm mute or reset button, and it silences an active alarm for 2 minutes. And then if you press it once the alarm is, resolved, and you can press it again and it'll clear all the active alarm page so you can see that main page screen. Number five is the alarm priority, and these alarms, so again, all alarms should be responded to immediately, regardless of the priority, but priority is based on the urgency. So, for example, some of the examples I had given previously, the red bar, red priority alarms are things like circuit disconnect or low minute ventilation or high pressure alarm, or like a serious error with the ventilator and it can't be used. So of course you want to assess for those right away. So a little more on the priority of alarms. So the high priority alarm requires immediate response, and you'll see the red flashing alarm on the screen. A medium priority alarm shows you yellow, and then a low priority alarm is just an information alarm, and you'll see a solid flashing alarm on the screen as well as a message on the screen. Okay, so here are some common built-in alarms. Of course, there's a lot more in the service manual, but these are some of the common ones that we may see in home care. So number one is ventilator inoperative, so servicing is required here. Anytime you get this type of an alarm, you want to take the patient off, manually ventilate them, call for help if you don't have the backup ventilator there, but manually ventilate them if they cannot be without ventilation. If you know a child can be without ventilation for a period of time, then you take them off and then switch them to the backup ventilator. Um, Total power failure is total loss due to failure of the internal battery, or you've lost external power while the internal battery is fully depleted. So here you want to switch to an external battery if it's charged up and you have that available, or you want to switch the patient to a charged backup ventilator. And then if you don't have an external battery available, you would manually ventilate the patient and call for help. If you get a power fault or no charging alarm, that means there's an issue with the charging of the ventilator. So here you again, you want to switch to the backup ventilator and call the ventilator equipment pool for servicing. If you're using the internal battery power, the ventilator will let you know that you're using internal battery power. So when you first power the device on, without it being plugged into AC power, it will indicate that you're starting on internal battery power. If the external power is disconnected all of a sudden, it will also tell you you're now on internal battery power. If there's ever a system fault, it could be any sort of a technical fault that's detected with the ventilator. It could be at initial power up, or it could be during ventilation. So you want to take the child off, manually ventilate them, switch them to the backup ventilator, and then call the vent pool for servicing. If there's a circuit fault, this means something's wrong with the circuit configuration, or something's going on with the circuit. You want to check and make sure there's no leaks in the circuit, that there's not a lot of water toggling in the circuit. And you want to perform what we call a learned circuit check. So this is specific to the Astral, to ResMed devices. We do teach families how to perform a learned circuit check. This is available on the Ventilator Equipment Pool website. So partner with the families, perform a learned circuit check. And a learned circuit check is something that is done routinely with families after they, for example, replace the tubing weekly, if they've taken anything apart on the ventilator and put it back together, or if the child is not comfortable on their ventilator, it's another thing for them to do to be able to sort of calibrate and let the ventilator know sort of this is the tubing that we're using, this is the configuration we're using for this patient, these are the settings, and it sort of establishes a baseline that is appropriate for that patient's settings and circuit type. So always good to do a learned circuit, and if you don't know how to do that, just partner with the family. And if the alarm persists, you want to replace the whole circuit. Okay, so again, switch the child, manually ventilate them, switch them over to the backup ventilator, and then replace the problematic circuit. Okay, so here is a list of some common alarms. These alarms are, oh, sorry, my apologies. Let's go back to this. Okay, here we are. So you'll see a lot of these alarms are hopefully familiar to you because they are on the Trilogy ventilator as well. So if you see, if you get an alarm for high pressure, for example, so that could mean airway occlusion, you could have a full or partial blockage of the airway or somewhere along the lines. We always start with the airway. You may see a change in the patient's condition. So they might have a lot of secretions, or they might be coughing. The tube might be blocked. You might not see, chest rising. There could be a blockage in the circuit, or maybe even incorrect settings on the circuit. So you always want to start with the patient, of course, and check that trach tube, suction. If it's blocked, you want to do an emergency trach change. Low pressure means that there are leaks in the circuit. So it could be in and around the trach, could be in the circuit, could be in the ventilator. The circuit disconnection is what you'll see on the screen. And sorry, you'll see pressure alarm on the screen, but low pressure can also mean that the patient's been disconnected from their circuit. So just keep in mind, you'll see pressure alarm, but it means low pressure. High respiratory rate is, so of course we always approach it as if the patient is in respiratory distress. So assess your patient, look at your patient, make sure the trach is in. You want to perform suctioning. If the tube is blocked, of course, perform an emergency trach change. And then other reasons could be things like pain, fever, infection, anxiety, it's a whole host of things, right, that can lead to high respiratory rate. Low-minute ventilation alarm. This could mean a change in the patient's condition. So maybe the tube patient has been decannulated with the ventilator attached. Partial or full obstruction of the trach. There could be secretions in the trach tube. And again, leak somewhere in the patient's circuit or in the valve somewhere. Like, it could be damaged, it could be more leaking, or obstruction in the somewhere in the patient circuit or the leak valve as well. So really what it's telling you that it's not being able to measure that exhaled volume. It's not able to, because we set the low minute ventilation alarm, so it's not measuring, it's not, it's sensing low volumes or a low respiratory rate. And in the cases of low volume, it means that in most cases that something's going on with the trach tube. So suction, ensure that it's not blocked, make sure the tube is in, make sure the child is connected. And of course, manage those leaks. Low tidal volume. So low tidal volume, essentially the same thing. So you want to check for leaks in the trach, in the circuit, in the ventilator area. And you want to make sure the patient is connected to the trach adapter. Two new settings. One is called disconnection. And there's two new settings that come along with that. So disconnection, on the screen, it'll show as circuit disconnection. So this is the same thing as circuit disconnect on the Trilogy ventilator. So just like how you had circuit disconnect, like a time for that, here we'll have an alarm activation time as well. So we would set that. So let's say 5 seconds. So after 5 seconds, if the child is disconnected for 5 seconds or longer, this alarm will ring off. So every patient will have their own setting for this as set by the clinical teams and on your care plan. So one will be the circuit disconnect tolerance. So this is new for this ventilator. And basically this alarm looks at the degree of disconnection. And if that degree of disconnection exceeds what we have set for this tolerance value, it will ring off. So for our recent patients, we set it around sort of that 40 to 55% mark, approximately there. But this is a number that will be determined by the clinical teams, and it is specific to the patient. So we will be testing that in the hospitals and then determining what that is, and you'll see that on your care plan as well. So when you see circuit disconnection, always go to the patient, make sure the tube is in, make sure the patient is connected, and then work your way down and make sure the rest of the circuit is connected as well. Okay, so when approaching alarms, again, first look at the patient, check their airway, ensure the trach is in. If it's pulled out, then perform an emergency trach change. Next, you want to suction the trach. If the trach is obstructed, you want to perform an emergency trach change as well. If the same size trach cannot go in, you want to attempt with the one size down. If that does not go in, then you will have to provide ventilation via the bag. So on patients, this will be via a mask on their face, so bag mask ventilation. For children that have a critical or difficult upper airway and they don't have a connection from their upper airway to their lower airway, this should be on their care plan, very well labeled. Then you will be using their stoma mask to ventilate the stoma. Number three, if you've looked at all of that, then you want to think about things like repositioning the patient, making sure, that their airway is aligned and that there is not a lot of leaking to the upper airway, and minimize any other types of leaking. Number four, you want to verify the settings are prescribed correctly if you haven't done that. So you want to just double check the settings and alarms that are set correctly. And if the alarm still doesn't stop, then you want to switch to the backup ventilator and call the ventilator equipment pool. You can also partner with the family to do a learned circuit test. And Again, you also want to then inform the clinical team, the ventilator equipment pool. You can reach out to us on Connected Care Live as appropriate. And then number 8, continue to monitor the patient as well. Here's a sample script. So you should have the ventilator settings on hand to double check the settings ordered with what is set on the ventilator. If you do find a discrepancy with the settings and what is ordered, have a chat with the family to see if anything has changed. Document clearly and ensure your supervisor is aware so that they may be able to get the clinical teams to send updated orders and call the family as well. When you arrive on shift, you will, uh, you should, so sorry, if you arrive on a day shift, right? Or if you're in a position where you need to be traveling or be mobile with the child, you do need to ensure that you have some sort of a travel checklist and that you're prepared for traveling, for example, taking the child to school or taking them to a clinic appointment. So we usually ask, what supplies will you need to pack? And, here we have things like your suctioning equipment, your emergency trach kit, the manual resuscitation bag with a trach adapter, with the masks and a stoma mask if needed, oxygen if needed, oximeter with enough probes, your travel ventilator fully charged with the backup batteries, the travel bag, so your cleaning supplies, any client-specific supplies, your feeding supplies, medications, care plan, etc. Contact numbers, which are very important. So if you haven't created a list, we do have it in the About Kids Health Connected Care Trach Manual, which you can refer to online, that has a traveling section as well. And then at the beginning of shift, these checks are very important to ensure that you have all the equipment on hand and sort of give you that peace of mind that everything is working and set properly. And then continue to familiarize yourself with these safety checklists. This is the one for invasive ventilation, and these can be found on the Connected Care resource page once you've logged in. Ventilator adjuncts. So we'll have a look at these, and not all patients will have these adjuncts, but they may have one or more. So here we see the inline nebulizer. This is for children that require nebulized medications or saline in line with the ventilator. So this is a setup for with the passive circuit, and you would do this, for example, it would be prescribed for a child that cannot come off the ventilator for medication delivery. So normally it would be like with a trach mask with the nebulizer, but in this case, we have put it in line for a child that's 24/7 ventilated. Here is a setup for an inline speaking valve. Always remember to place the speaking valve closest to the patient and after the exhalation leak valve. So on inhalation, the ventilator will deliver the breath to the patient. On exhalation, the breath cannot go back into the exhalation port because the speaking valve has a valve that's only one way, so it can go in, but it can't go back out. And then, so in this case, then the air is directed to the upper airway. On the Astral ventilator, since it does allow for different program, you may or may not see the clinical team set one for speaking as well. And so you can switch the child over to a speaking valve setting if it is set. Otherwise, just keep them as prescribed on the current settings. And then one thing to highlight here, of course, is if the child has a cuff tube, anytime you're initiating a speaking valve, huge safety point here is that you want to make sure that that cuff is deflated. So the cuff cannot be up when a child has a speaking valve. Inline sectioning. So inline section catheters can also be added to the Astral circuit setup, just like they are for the Trilogy ventilator. Here you see a child that has, so this is from ResMed, and you see them show a child with a dual limb circuit. So it's one of those smaller diameter baby circuits. So dual limb circuit with an inline sectioning catheter. We do have information on inline suction catheters on our Connected Care website. So we have a quick hit on this, and it's instructions on how to use it as well. And if you need more information, please reach out to us anytime. And then ventilation delivery is considered an aerosol generating medical procedure. So therefore, when providing care, home care providers, nurses should be wearing mask, gown, gloves, and eye protection. If the child is off ventilation, PPE would be routine, and nurses would don, additional PPE for things like ventilation and suctioning and performing cough assist therapy, etc. And then Connected Care Live, for those of you who are not aware, is a web-based application that you can access from any phone, computer, or iPad. The aim of this program is to connect community care nurses to evidence-based practices, resources, and the ability to consult with a sick kids nurse through text talk or video 24 hours a day. And so you can use this platform in preparation, during, or even after a shift. And as a community provider, you can look through the resources yourself or use them on your own, and you can initiate a consult with the sick kid nurse to help you out. Um, yeah, so make note of this, and if you're not registered for Connected Care, you would do that right from the this website as well on the top right-hand corner. Here is the website for the ventilator equipment pool once again. Here you'll find the additional resources, manuals, and cleaning guides, and some videos on the equipment that is um, funded and provided by the ventilator equipment pool. So in summary, today we've reviewed the indications for the Astral ventilator or indications to invasive ventilation. We've reviewed the Astral ventilator, some of the alarms offered on this ventilator, and the safety checklist as well. So at this time, I will stop the recording and open it up to any questions. If you do have a few moments, if we can kindly ask you to complete this online evaluation. So you would just scan your QR code and just fill out a few questions for us. That'd be greatly appreciated. Thank you so much.